next segment is the college lecture. We're grateful for today's speaker, Dr. Sonali Gunatilaka, the consultant endocrinologist from District General Hospital, Nuwara, for accepting our invitation to speak today. And this segment is actually supported by Sidus Kemas. And introducing Dr. Sonali, she has completed MD Medicine in 2015 from University of Colombo with the gold medal for the best performance. She had overseas training in Oxford University and Cambridge University NHS Trust. She has special interest in bone-related endocrine diseases and pituitary disorders. Contributed to several guideline development projects both nationally and internationally, and she's the author of several peer-reviewed articles published in international journals and book chapter in Endotext. Currently, she is attached to the Nuwara Hospital. And thank you very much, Sonali, for being here. And your talk today is on new era in diabetes battle. What do you do?
Thank you, sir. First of all, I would like to express my gratitude and sincere thanks for the President Council of the CCP for giving me this opportunity. So without further ado, today's topic I'm going to talk is on new era in diabetes battle. I declare there are no disclosures. So without further ado, if we talk about goals in management of diabetes. Well, diagnosis of diabetes itself is a very depressive condition. Patients get frustrated, especially if they are young. Lot of factors involved in it. Patients have to be on medications and a lot of information. And patients have to be on lifestyle modifications, so a lot of things to take in, and that will also affect the quality of life, as well as disease-wise, it reduces mortality and morbidity. So the aim of this management of diabetes is to improve the mortality, morbidity, as well as improve the quality of life, and that is by mainly through reducing complications as well as improving the glycemic control. Now, all of us, you, me, and all of us have been doing this throughout the years up to now. And what have we been doing to manage diabetes? I would not go into details of the individual topics, but in management of diabetes, the main principle is early tight blood glucose reduction to improve the microvascular and macrovascular complications that a patient can get. So if somebody targets an early tight blood glucose control, the patient will have less number of micro as well as macrovascular complications immediately, as well as with the legacy effect of tight glycemic control. So that is our first target in management of diabetes. Second one would be an individualized HbA1c target, and to achieve the target, we use several classes of anti-diabetic medications, including tablets as well as insulin. You may appreciate there are different percentages of HbA1c reduction in different classes of medications, but using these medications, achieving an individualized HbA1c target is our second principle. And not to forget, controlling risk factors and prevention and treatment of complication of diabetes is the next target in management of diabetes. So this had been practicing all over the world as well as within us to manage patients with diabetes mellitus. Now, are we reaching the targets? Have we done correctly? Yet, up to date, still, diabetes has been the primary cause of visual loss worldwide, including Sri Lanka. It is the major cause of end-stage renal disease. And also, even now, every 30 seconds, a lower limb is lost throughout the world due to complications of diabetes. And there are issues with the pregnancies and many other aspects, including increased risk of cardiovascular disease. And going into the international data, you may appreciate that this is UK data. When we consider achieving HbA1c, blood pressure, and cholesterol targets, less than 50% of patients with diabetes have achieved these targets. And mind you, this is in the United Kingdom. How about us? This data is from 2016 from one of our leading clinics, the Sri Lankan data. And if you see, macrovascular complications were seen in about 13% of our diabetic patients. And surprisingly, 74% of our patients had microvascular disease. If you compare with other countries, again, they are also having high numbers, but microvascular complications, we are leading. So we are actually not doing in the optimal way we have to do, but there are many factors contributing to it. Having this background, let me start my discussion on new era in diabetes battle. So I'll be talking on under several topics. And okay, diabetes mellitus, when we take the mortality and morbidity, if you see this red color one, that the contributing to mortality, sudden cardiac deaths constitute of 30% of diabetic deaths. And if you combine all these acute MIs and heart failures, majority of the deaths will happen due to cardiovascular diseases. And the rest would be non-CV deaths. So 66% will be cardiovascular deaths. And if we see the history of or the progression or natural history in type 2 diabetes mellitus, what happens is the glucose levels are high. That will lead to complications, especially cardiovascular, and that will lead to cardiovascular deaths as well as non-cardiovascular deaths. So this is what happens to a patient with diabetes mellitus. So what do we as physicians do? We treat these patients with oral medications and maybe insulin or other injections, targeting a good glycemic control, thinking that good glycemic control will ultimately prevent development of cardiovascular and other complications, and that will prevent deaths. So that's the sequence that we expect these patients to have. Do we have evidence? Yes. A lot of trials, including UKPDS and many other trials involved with many different classes of drugs, do provide evidence for this scenario. Good glycemic control will prevent deaths and complications. But what if we, in addition to this classic pathway, what if we target the complications directly or deaths directly? What if there is an agent which will act on these organ systems as well as reduce cardiovascular deaths in addition and independent of glycemic control? That will be an advantageous situation. So we will be targeting the organ complications as well as reducing cardiovascular deaths. Now we know that there are several classes of drugs even now which is available in the market which have shown evidence to do this. Although it is not a new thing, but it is some eye-opening to move forward from this end towards a better future. SGLT2 inhibitors, I would not be talking in depth of these, but they have shown a significant cardiovascular benefit to reduce the cardiovascular deaths as well as other cardiovascular events in patients who are on SGLT2 inhibitors, those who are having diabetes. Further studies have shown even in patients without diabetes, they have brought some good effects and cardiovascular benefit, but I'll be focusing on patients only with diabetes. Especially empiric outcome trial has shown to reduce cardiovascular deaths as well as heart failure hospitalization. And as a class effect, all the drugs basically have shown significant effects in reducing cardiovascular, heart failure hospital admissions. And if you see in this graph, this cardiovascular benefit has occurred in this empiric outcome trial very early in the course of the trial. If you see this, These are months. And in the early stages of using this medication, the two lines have splitted. It means that the effect, cardiovascular effect, has occurred in the very early stages of using this drug. So this is independent of the glycemic control, because we know that glycemic control will take several years to bring about the benefit of macrovascular complications. So this drug is affecting the cardiovascular system directly and bringing benefits. How about renal outcome? What about the kidneys? Several studies on SGLT2 inhibitors have shown that there's a composite good renal outcome, especially with regard to progression of microalbuminuria and end-stage renal disease progression, and favors a renoprotective action of SGLT2 inhibitors. This again shows somewhere around 40 to 50% reduction in composite outcome, progression of albuminuria, as well as end-stage renal disease in patients who are on SGLT2 inhibitors. So ladies and gentlemen, SGLT2 inhibitors, in addition to reduction of glycemic levels, it directly affects the cardiovascular outcome as well as renal outcome, with beneficial effects to cardiovascular and renal system. How about GLP-1 agonist? I'm sure you all know what GLP agonists are, although it's not very readily available, but it is an incretin hormone which is secreted from the small intestine, and that goes to the pancreas, beta cells, and increases the insulin secretion as well as reduces the glucagon levels. Now, because of these effects, it will promote good glycemic control. In addition, it has effects on the brain, the deepest nuclei and the systems, to reduce appetite, as well as it slows down the gastric emptying. They have manifested in other ways, like reduction in weight, in addition to glycemic control. So these medications, apart from the glycemic control, have shown cardiovascular outcome. And what are they? This systematic review, this meta-analysis, including several studies done on GLP-1 analogs, have shown a favorable 3-point maze favoring the drug to be cardiovascular protective when used in patients with diabetes. Is very it's kind of a good result when we think of mortality and morbidity, and supporting and showing similar effects to SGLT2 inhibitors. And again, lead trial with done with the liraglutide again shows similar results with cardiovascular benefit. You can appreciate the two lines being separated at the end of 48 months, showing cardiovascular benefit with reduction in cardiovascular events, ultimately improving the mortality and morbidity. And how about renal outcomes? Again, GLP-1 analogs, they have shown composite renal endpoints and progression to macroalbuminuria in a manner that they have a favorable outcome in patients with diabetes. Therefore, and again, another study, REWIND study, also shows the red line indicating dulaglutide compared to placebo has shown significant improvement of renal outcome when used in patients with diabetes. And this is in addition to the good glycemic control. Therefore, ladies and gentlemen, both SGLT2 inhibitors and GLP-1 agonist drugs have shown a favorable outcome in terms of renal protection as well as cardio protection, and leading to reduction in cardiovascular deaths directly and independently of glycemic control effects. So this is, although not very new, this is kind of a turning point in diabetes management, and which is very beneficial for the patients, as well as it improves mortality, morbidity, and quality of life. Okay, moving forward, this is a new drug which was released. We are talking about dual incretins, or we call Twincretin effect. we talked about GLP-1 agonists. There's another similar incretin produced in the GI tract, which is called GIP. It's not GLP-1. What are they? GIP and GLP incretins have somewhat similar actions. They both increase insulin levels and improve the glucose levels in the body. But taken alone, GLP is more stronger than GIP. But in combination, they act synergistically and brings about a greater effect compared to the single agent alone. So what it does is it changes the satiety as well as reduces gastric emptying, thus cause weight reduction, as well as increases insulin secretion to cause reduction in blood glucose levels. So the drug is called Tirzepatide, and that is a combination of these GIP and GLP-1 receptor agonists. And it has effects on pancreas, like I said, as well as brain and white adipose tissues to bring about its effect. And we talk of let's talk about mainly the glycemic effect. The ash line in this trial is the placebo. And blue lines and the purple lines are different strengths of Tirzepatide given in this trial to the control as well as the test arm. You can see there's a significant reduction in HbA1c among the patients who are being treated in the trial. Same thing in the body weight arm. Placebo group compared with the treatment arm, there's a significant reduction in the body weight. If you see the numbers, somewhere around 8% to 11% reduction of body weight, which is a very significant number reduction in the body weight when given this drug. How about the cardiovascular outcome things? Does this drug affect the cardiovascular system in a great way like the drugs that we have discussed previously? Well, in this meta-analysis, you can see that the 4-point MACE as well as 3-point MACE and all-cause death, they have not shown superiority, but same way it has it has not shown to be harmful as well. So it is neutral and it is non-inferior in other terms, but there are no specific superiority of this drug, but it's harmless drug, cardiovascular-wise safe. This SURPASS-2 trial has compared this new combination drug together with one of its components, GLP-1 agonist, that is semaglutide, and compared to one drug alone, this the combination drug has shown to be more beneficial if you see the trial. And if you see this ash bar or ash line, that is the semaglutide alone. In blue lines, it shows the combination of GLP-1 as well as GIP. And when we consider HbA1c, there's a significant reduction in the combination drug compared to the single agent alone. Same way, this is the weight reduction. Weight reduction is also, there's a significant reduction. In semaglutide, the mean reduction is minus 6.2 kilograms, whereas in the combination Tirzepatide medication, the range is from 7.8 to 12 kilograms. That is a significant reduction in weight using this drug. So, in conclusion, GLP-1 receptor agonist and GIP combination drug has shown to be having very good effects on HbA1 reduction as well as weight reduction. Now, we talk of weight reduction since old ages with metformin, but just see the anti-diabetic medications with weight reduction. Metformin comes here, a very mild reduction, but the range is very high. But if you take the stronger effects with liraglutide, Tirzepatide, and semaglutide, they show a significant weight reduction of ranging from minus 7.5 to minus 2 kilograms, depending on the dosages. The problem with liraglutide, although it is placed at number 1, is with higher doses, the side effect profile is much more. Therefore, only very few patients do tolerate, whereas Tirzepatide, the dropout rates are there, but comparatively liraglutide, with current evidence, it is much better tolerated according to the literature. Okay, so let's move on to the other aspect of diabetes management, that is reversal or remission or prevention of diabetes. We all know that diabetes, nowadays we talk about remission or reversal of diabetes. The main study involved is direct study, where they have taken patients with type 2 diabetes within 6 years of diagnosis and having a BMI of 27 to 45. And this is a primary care based study where they have put all these group of patients into a total diet replacement of somewhere around 830 kilocalories a day. Our usual calorie intake is somewhere around 1,005, 2,000 if you're obese. But you can see it is a very very low calorie, although the cutoff is 800, it's 830 kilocalories. It's the cutting down of major part of your diet. And this was followed by fluid reintroduction and weight maintenance. And the outcome measures were weight loss of 15 kilograms and a diabetes remission, that is HbA1c less than 6.5. So what have they found? They have found that at 24 months, 46% of the study population had diabetes remission, as well as 24% has achieved the target of weight loss of 15 kilograms, and drug discontinuation was there in 74%. So this is by the dietary interventions, and diabetes has gone into a reversal or remission in 46% of this study population. Nearly half of these patients have had no diabetes at the end of the study. So they concluded, this is the initial phase of this trial, type 2 diabetes up to 6 years duration, because the patients were recruited within 6 years of diagnosis, can be reversed by weight loss with help of evidence-based structured weight management program delivered in the community. I'm sorry, this is at 12 months, the initial phase. Now, they have followed up these patients up to 24 months. And you can see that 46% has dropped to 36%, but still at the end of 24 months, 36% have remained in remission. And that was also very significant. And they concluded that 36% in remission at 24 months and 70% in remission with more than 50 kg loss. So if somebody loses about 15 kilograms, 70% there's a chance of getting remission of diabetes. What is the real data? This is the clinical trials. Can we achieve this? Well, this is a study where it was done in the normal setup without any major dietary interventions. They have found that only 3.3% patients with routine care has gone into diabetes remission. So without a major dietary or lifestyle intervention, there is a chance of diabetes remission, but it is less. But if we intervene with targeting the weight reduction, then we can achieve a better diabetes remission. And imagine somebody having diabetes and then after some time calling them free of diabetes. That's a reward. So we should be aiming diabetes remission or reversal in the selected group of population with diabetes. Now, this initial direct study was targeting patients with high BMI, that is more than 27. What if a patient has diabetes with thin built, or like having a BMI of less than 27? Again, the Retune study has looked into this, and then they have found that even a patient with less BMI, a BMI of less than 27, still if we put them on a diet which is restricted with calories, targeting a 5 to 10% weight loss, still they can achieve diabetes remission. Compared to the baseline starting weight, achieving some kind of a weight reduction from 5 to 10%, still they can have a diabetes remission. And how about bariatric surgery? Now we talk about weight loss and diabetes remission. Bariatric surgery is well known to give rise to a significant weight reduction and followed by diabetes remission. Now this is the first two columns are observational studies. The second one is RCTs. In both studies, the red one are shown in indicating bariatric surgeries, and the blue ones are conventional treatments. So diabetes remission is achieved in more than 50% of patients undergoing bariatric surgery in both RCTs as well as observational studies. And the effects are mainly due to incretin effects and insulin effects, as well as hepatic insulin sensitivity, many effects. And this had been persistent during the course of follow-up of these patients. And just to share the early experience, Dr. Bulgahapiti is also here. Under his guidance, the bariatric surgeries done at Kalubowila Hospital, we have seen our real-life Sri Lankan data. This is only a part of the cohort. Now it's a massive cohort nowadays. And this is with, actually, I didn't get direct permission, but this photo was on the internet with in one of the sites where the experience was described. You can see that of the initial cohort, 42% who had diabetes, out of them, 61% had gone into complete remission of diabetes. These are Sri Lankan people. And 31% had gone into partial remission of diabetes. Out of the pre-diabetes group, which was 22% initially, 71% has gone into complete remission. So it is a possibility, and that is mainly through weight reduction and some changes in the GI hormones, which we are not quite sure what they are exactly, but this is real life evidence of diabetes remission. So this was, I think, published by the team later on. And so, ladies and gentlemen, type 2 diabetes remission or reversal is something that we haven't talked about previously. Now we talk about it because it is achievable, doable, and we have enough evidence to achieve it in control trials as well as in real life. How about type 1 diabetes? Can we reverse it or can we go into a remission? Unfortunately, there are no evidence to reverse type 1 diabetes, but in preventing the type 1 diabetes, there is good evidence. Now, if we take the beta cells, there is an autoimmune way that they are being attacked through APCs and effector T cells, and beta cell masses decline over time in type 1 diabetes. And this is mediated via CD3 receptors. And what if we block this CD3? Teplizumab is an anti-CD3 monoclonal antibody. Now, this has shown, using this drug, has shown in preclinical studies to preserve C-peptide or insulin levels in patients who are at high risk of developing type 1 diabetes. That is, the relatives of patients who have type 1 diabetes, in them, using the drug has shown to preserve the beta cell function compared to those who did not receive the drug. What is the real life or clinical trial data? This study has shown that in patients with high risk of developing type 1 diabetes, that those are the relatives of type 1 diabetic patients, using this drug, that is teplizumab, has shown to have delayed the development of type 1 diabetes compared to placebo. Now, if I just tell this results found, teplizumab group had developed diabetes at the mean of 48 months, whereas placebo group developed it at 24 months. And type 1 diabetes was diagnosed in 43% of this treatment group, whereas 72% has developed type 1 diabetes in the placebo group. So you can delay the development of type 1 diabetes if somebody uses this drug, and this has FDA approval now. Okay, Now, lastly, I'll move on to technologies in type 1 in diabetes. So continuous glucose monitoring. What we use is glucose strips and monitoring sugar levels through finger prick as well as blood test. Now, this is a device where we put the sensor in the subcutaneous tissue, and this sensor will detect the glucose levels at every interval, 15 minutes, 10 minutes, so on. And then it will go on monitoring the sugars, and the patients will not feel anything. But at the end of the day, you can get a graph as for how the sugars have varied. In this patient, the sugars have risen just before 9 o'clock and again midday. Likewise, every day you get a different pattern in a different color. And this is a very good indicator of undetected hypos as well as undetected hypers. So you can see how you stand or how you go about. This is, unfortunately, it's not freely available in Sri Lanka, but this is the technology that we use to detect patients with recurrent hypos and high unexplainable HbA1cs and so on. What about this? This is called flash glucose monitoring, where a sensor is placed on the arm, and then you have a device where you swap, and then the reading comes into your device. Even a mobile phone can be used, and it again gives rise to the number of like the glucose levels depending on the number of swipes that you do on your sensor. And even somebody else can swipe and then check on your device whether the patient is having high sugars or low sugars. You may see this is Theresa May, previous UK Prime Minister. She's diagnosed with type 1 and having this Freestyle Libre sensor. Now, conventionally, our traditional blood glucose checking methods, what we think the best would be HbA1c. But nowadays, the trend is moving towards time in range targets. So where for a given time, we assess the patient having the target blood glucose levels and how much of time the patient is in target. So green mark indicates that 70%, this is the target, more than 70% of a patient's time, he or she should be in target, whereas we can allow less than 4% of time to have hypos, as well as less than 25% of the time to have hypers. So this is what is coming forward. And why is that? If you see a patient with HbA1c 7%, this patient can have a glucose profile in any of these conditions. So it could be either 100% in range, or mildly elevated blood glucose levels, or having elevated as well as very low blood glucose levels with marked fluctuations. All these patients will have HbA1c 7%, and this will not indicate what the patient is going through. But if you use time in range, you can see the different times in range of this blood glucose profile, and that would be the future for us to manage diabetes. And time in range has shown much evidence as well. And again, continuous glucose monitoring, when used, you can see the lower part of the curve is when a patient is using continuous glucose monitoring, the HbA1c is much less compared to when patient is not using the continuous glucose monitoring. And again, this study shows that the green line is where the CGMs or flash glucose monitoring is done very frequently. They have a better glycemic control compared to those who don't use the flash glucose monitoring, don't check the glucose much often. So continuous glucose monitoring and time in range will be the future. Insulin pumps, I would not go into details. Using insulin pumps, especially in type 1 diabetes, to manage diabetes has been practiced abroad, and some of our patients also have. And then this insulin pumps together with the CGMs, continuous glucose monitoring, and having hybrid loop systems, that is monitor talking to the pump and then telling, okay, this is the sugar levels and you should deliver this much of insulin to the body. that is acting like a pancreas artificially made in our body, although our pancreas is not working. So this is called artificial pancreas, and that is the future of type 1 diabetes. Not to forget other transplant methods. Islet cell transplant is being practiced in other countries, and then you may appreciate that the blood glucose levels following islet cell transplant has come down, as well as requirement of insulin has come down markedly following the islet cell transplant. So this is the new era of management of diabetes, both type 1 and type 2, but not to forget the challenge that we face. Prevalence of diabetes in Sri Lanka has gone up to 23%. So that is again a challenge in this era of diabetes, and you and I will have to face increasing numbers of patients having diabetes, and we will have to manage them and expect larger numbers, crowding of clinics, as well as project our future to treat the complications, as well as apply the new modalities of treatment to improve the quality of life and reduce mortality and morbidity of these patients. Thank you.
Thank you, Sonali, for that excellent presentation. I think you can pass into what's can do in future as well as what we can do now. Any questions? So now, whatever we have it here, I think patients with, I'm handling with rheumatoid and diabetes. I find the main problem is the diet control. How much can this new technology overcome that, in spite of patient taking not adherent to the whatever advice we give?
Well, the management is a combination of lifestyle modifications as well as the medications. In practice, we have seen that although we use GLP2 inhibitors, if the patient is not compliant with the diet and lifestyle modifications, it's very difficult to achieve the targets. So it's both the combination of new medications as well as the lifestyle modifications. And even in reversal, we talk mainly of the lifestyle modifications and the diet. So reversal is brought about mainly by the diet in these studies. So together with weight loss, but diet and lifestyle modifications play a big role.
This weight loss using reversal all must be obese patients.
Not really, like I mentioned, mainly for the first study was done on obese patients, but even with patients who are having BMI less than 27, it is achievable. That is it's a new theory coming up. Compared with the baseline weight or BMI, if we can reduce the weight for a certain degree where there is a change in the fat tissues, then remission is achievable even in patients who are thin.
This thought I described SGLT inhibitors and GLP1a in the different cardiovascular morbidity and patients newly diagnosed with diabetes and morbidity starts to occur early. Are there other studies to demonstrate newly diagnosed diabetes giving statins as even though the cholesterol may be normal, whether that has a similar effect in addition to the glycemic control? Are there any studies that have thrown light on that matter? Because we know that cardiovascular morbidity and mortality is the main thing that is that causes prognosis in diabetic patients. So have those been assessed to the degree of GLP1 and GLP2 inhibitors?
Yeah, thank you very much for the question. Just to clarify, all the SGLT2 and GLP1 receptor agonist trials, not all of them are based on newly diagnosed patients. So there were patients, like most of the trials were having patients who had atherosclerotic cardiac disease versus high-risk patients. So not the newly diagnosed patients per se, and the benefit has been shown mainly in the patient groups where they had atherosclerotic cardiovascular disease compared to high-risk groups. With regard to aspirin and statin, there were no head-to-head comparison with SGLT2 inhibitors and GLP1 agonists. And as far as I know, there are no new trials as for prevention of cardiovascular disease, mainly targeting aspirin alone or statin alone. I think they have been like running in 2 different arms separately. And most of these patients who were on trials had been on aspirin statins as well. So these effects had been on top of that preventive effects of aspirin and statin.
Thank you very much. Thank you very much for taking our invitation and being here to be with us today and give this excellent presentation on behalf of the college.